Sellar and Suprasellar Mimics, a case review series. Angela Snyder, D.O., Natalia Naghornaya, M.D. Karifsidani, M.D., Rita Bhatia, M.D. Presentation #ADA1407366. Disclosures. The authors have no disclosures. Purpose. Mimics of typical sellar and suprasellar lesions are relatively rare and can present a diagnostic dilemma with vital therapeutic implications. The authors report a pictorial review of various common and uncommon mimics of sellar and suprasellar lesions. Also included are atypical presentations of common lesions, approach/methods. Retrospective case review of patients presenting to the Department of Radiology at Jackson Memorial Hospital and the University of Miami MRI Center. Included are atypical lesions of the sellar and suprasellar spaces, as well as more common lesions found at these locations with atypical imaging characteristics. Findings. We present multiple cases in which uncommon sellar or suprasellar lesions have the appearance of other more often encountered masses of this location. We also present atypical imaging characteristics of more common lesions. Case number 1. Optic chiasm cavinoma. Clinical. May be asymptomatic, greater than 30% become symptomatic, usually in 20s or 30s. Acute, visual disturbance, subarachnoid hemorrhage, seizures. Chronic, progressive visual loss, headache, endocrine dysfunction. Behave as all cavinomas. Hemorrhage rate of all cavinomas, 0.7 to 1.7%/lesion/year. 20% familial, autosomal dominant. Imaging. CT, well-delineated hyperdense mass plus/calcification, negative in up to 50%. MRI, popcorn appearance on T1 and T2 common, hypointense hemosiderin ring on T2, blooming on GRE, minimal/no enhancement. Look for associated developmental venous anomaly. DDX, AVM, aneurysm, optic gloma, craniopharyngioma, pituitary apoplexy. Texas, somewhat controversial, 50% stable vision and 50% progressive visual loss. With resection, partial or complete, 87% improved vision. Stereotactic radiation therapy proposed but not well documented, anterior optic pathway sensitive to radiation. Cavernous malformations, American Association of Neurological Surgeons, 2008 July. http://www.ans.org/patient%20 information/conditions%20 and %20 treatments/cavernous%20 malformations.aspaccess September 22, 2014. Crocker, M., D'Souza R., King A., et al. Cavernous hemangioma of the optic chiasm, a surgical review, Skullberset 2008 18-3, 201-12. Case number 2. Case number 2, continued. Early ritica, late ritica, arteriovenous malformation. Clinical. About half present with headache secondary to hemorrhage. More than half have an associated aneurysm. Till the 1/4 have associated seizures. Patients may have progressive neurologic dysfunction secondary to related hypoperfusion or microhemorrhage. Imaging. Bag of worms, tangle of vessels. MRI, honeycomb of flow voids, may have blooming on GRE if hemorrhage, nichus enhances, enlarged feeding artery/IS and early draining veins. DDX, other vascular malformations such as dural avenue fistula or cavinoma, vascular neoplasm/metastasis, meningioma. Texas. Embolization. Stereotactic radiation therapy. Surgical resection. Spetzler-Martin score utilized, surgery typically avoided with a score of 4 or 5. Based on size of nichus, venous drainage and involvement of eloquent cortex. Gebresetes, Pong Chess, Giarokongman P. et al. Radiologic assessment of brain arteriovenous malformations, what clinicians need to know. Radiographics 2010 32, 483-501. Santos M., De Martinez ed., Matosel, et al. Angioarchitecture and Clinical Presentation of Brain Arteriovenous Malformations. Arc Neuropsychiatric 2009-67 2A, 316-21. Case number 3. Case number 3, continued. Bilateral petrous apex ceca aneurysms, partially thrombosed. Clinical. May present with sensory neural hearing loss, most common, cranial neuropathy, pulsate alternatus, epistaxis, stroke. Underlying causes, i.e. connective tissue disorder, are atypical. Possible causes of acquired aneurysm, radiation therapy to the skull bursa, prior trauma, skull bursa infection. Important to evaluate for additional intracranial aneurysms, especially with those suspected to be congenital. Imaging. CT, osseous erosion, curvilinear calcification, enhancement. MRI, T1 and T2 heterogeneous, may see a swirl pattern on T2, clot may bloom on GRE, enhancement. CTA preferred diagnostically. MRI can demonstrate hyperintense T1 signal with cholesterol granuloma that appears as flow-related signal. DDX, cholesterol granuloma, fibrous dysplasia, encephalocele, petrous apicitis. Texas, balloon trapping, stent placement, sacrifice of ECA with ECA to MCA bypass. Chapman P., Shah, Cure J., et al. Petrous apex lesions, pictorial review. American Journal of Röntgenology 2011-196:W.S. 2637. Razor K. Huang B. Lesions of the petrous apex, classification and findings at CT and MR Imaging. Radiographics 2012-32-1, 151-73. Case #4A. Case #4B. Macroadenoma, mimicking tuberculum cellular meningioma, 4A, and craniopharyngioma, 4B. Clinical. Typically present with endocrinopathy or visual disturbance. Most common suprasellar mass in adults, no man appearance. End organ failure in adolescent males can lead to pituitary hyperplasia with an adenoma-like mass. Imaging. No separate pituitary gland identified. MRI, T1 and T2 isointense, heterogeneously enhancing. By definition, greater than 10 mm, if greater than 4 cm, giant macroadenoma. May appear invasive, however pituitary carcinoma is extremely rare. DDX, pituitary hyperplasia, metastasis, meningioma, craniopharyngioma, aneurysm. Texas, surgical resection, typically transvenoidal. Transvenoidal resection likely to fail when lesions are solid and enhancing with restricted diffusion. 35% recurrence rate over 20 years. Boxerman J., Rog J., Donahue J., et al. Preoperative MRI evaluation of pituitary macroadenoma, imaging features predictive of successful transvenoidal surgery. Armer J. Röntgen 2010-195 3, 720-8. Hiram P., Kerr D., Cohen A. Primary hypothyroidism mimicking a pituitary macroadenoma. Pediatric Neurosurgery 1998 4, 195-7. Case number 5. Macroadenoma with apoplexy. Clinical. Typically present with sudden onset headache, severe nausea, visual disturbance, altered mental status. Most patients have an underlying macroadenoma. 1% of macroadenomas will hemorrhage. Usually middle-aged, more common in males, peripartum females also at risk. Imaging. CT hyperdensity, MRI blooming within the cella, rim enhancement suggests underlying hemorrhage, may have associated subarachnoid hemorrhage. MRI characteristics depend on age of hemorrhage. Acute hemorrhage is T1 isointense and T2 hypointense, may see diffusion restriction early. Commonly see associated dural thickening/enhancement and/or mucosal thickening of the sphenoid sinuses. DDX, craniopharyngioma, Rathke cleft cyst, non-hemorrhagic macroadenoma, aneurysm, abscess. Texas, surgical decompression/resection of underlying macroadenoma, supportive therapy. Bolus A, Napoli A, Romano A, et al. Pituitary apoplexy, an update on clinical and imaging features. Insights into Imaging 2014-56, 753-62. Semple P, John A. J., Lobsam, et al. Pituitary apoplexy, correlation between magnetic resonance imaging and histopathological results. Journal of Neurosurgery 2008-185, 909-15. Case number 6, 2 different patients. Meningioma clinical imaging. 1/3 of all incidental intracranial neoplasms. 3 to 10% of meningiomas arise from the tuberculum cellar. More common in women, typically between 30 to 60 years old. SX, headache, visual disturbance, anosmia. Up to 2/3 involve at least one of the optic canals. Imaging. CT, 3/4 hyperdense, 1/4 at least partially calcified, underlying bone hyperostotic. MRI, hypo to isointense on T1 and T2, look for dural tail, early and prolonged enhancement, mother-in-law sign. DDX, macroadenoma, metastasis, sarcoid, nerve sheath tumor. Texas, watchful waiting if asymptomatic, surgical resection if symptomatic. Immediate post-operative improvement in vision in 2/3 presenting with visual disturbance. Resection complicated by proximity to adjacent arteries, optic nerves/chiasm and hypothalamus. Sclari, Schatz N., Glaser J., et al. Optic tract edema in a meningioma of the tuberculum cellar. AJNR Arm J Neuroradial 2000-21 Nakamura M., Rosa, F., Struck M., et al. Tuberculum cellar meningiomas, clinical outcome considering different surgical approaches. Neurosurgery 2006-59-5, 1019-28. Mahmood M., Nader R., Al-Mefti-O optic canal involvement in tuberculum cellar meningiomas, influence on approach, recurrence, and visual recovery. Neurosurgery 2010-67 3 suppleoperative, 108-19, case number 7. Chondrosarcoma clinical imaging. Only 7% of all chondrosarcomas are craniocervical. SX, headache, cranial nerve palsies, CN6 most common. Symptoms usually present long before diagnosis. Imaging. Typically centered at the petrooccipital fissure. Chondroid matrix calcification on CT, osseous destruction. In greater than 50%. MRI, T1 iso to hypointense, T2 hyperintense, heterogeneously enhancing, may have whirls of enhancement. ADC values may show benefit in distinguishing from chordoma. Chondrosarcoma typically has a much higher ADC value, 2000 square millimeters per second compared to 1500 square millimeters per second for classic chordoma and 900 square millimeters per second for polydifferentiated chordoma. DDX, chordoma, chondromyxoid fibroma, metastasis, plasmacytoma, meningioma. Texas, typically combined radical resection and adjuvant radiotherapy. Block O, Pasa A chondrosarcoma, evidence-based treatment paradigms. Neurosurgery Clinics of North America 2013-24 1, 89-96. Kunesh M., Gunaldi O., Tugq B., et al. Intracranial chondrosarcoma, a case report and review of the literature. Minimum invasive neurosurg 2009 52 5-6, 238-41. Yom K, Lobera, Mobley B, et al. Diffusion weighted MRI, distinction of skull-bursecodoma from chondrosarcoma. AJNR J Neuroradial 2012 November 1. EPUB ahead of print. Case number 8. Case number 8, continued. Chondromyxoid fibroma. Clinical. 2/3 occur in long bones, 1/4 in flat bones, craniofacial extremely rare. Slow-growing and locally destructive, no tendency to metastasize. About half present in the second decade, males more common than females. Most present with very slowly worsening bone pain. Imaging. CT, geographic lesion with a sclerotic margin, thinning of cortex, usually expansile. MRI, T1 isointense, T2 hyperintense with lobulations, periphery T1 and T2 hypointense, minimal diffuse central contrast enhancement. DDX, chondrosarcoma, aneurysmal bone cyst, fibrous dysplasia. Texas, surgical excision with curettage and bone grafting, recur in tilde 20%, may radiate if recurrent. Crocker M, Konzar, Body I, et al. Chondromyxoid fibroma of the skull bursa invading the occipito-cervical junction, report of a unique case and discussion. Skull bursa 2010-22, 101-4. Haygood T, Herndon M, Chitkara P, et al. Chondromyxoid fibroma involving the sphenoid sinus, case report and literature review. Radiology case reports 2010-52. Case number 9. Primary pituitary lymphoma. Clinical. Incidence of primary CNS lymphoma has significantly increased over the last 30 years due to increased survival rates of patients with AIDS and increased rate of successful organ transplantation. 2.5% of AIDS patients will develop primary CNS lymphoma. Based on the 28 reported cases of primary pituitary lymphoma as of 2012. Equal incidence in men and women. Typically in the 6th decade. Presenting symptoms included endocrine dysfunction, 50%, headache, visual disturbance, and other cranial neuropathies. Imaging. Typically hyperdense on CT, although may be isodense, may see areas of hemorrhage and or necrosis. T1 and T2 iso or hypointense, may show diffusion restriction, may homogeneously enhance except for possible areas of necrosis. DDX, metastasis, sarcoid, lymphocytic hypophysitis, in our patient, toxoplasmosis, glioblastoma multiforme, metastasis. Texas, chemotherapy +/radiation therapy +/surgical resection. Manser, A, Kandil M, Abdulrazak H, et al. Mr. Imaging features of intracranial primary CNS lymphoma in immune-competent patients. Cancer imaging 2014 hours 14 minutes 22 seconds -30. Rainsbury P, Michelinus A, Clifton N, et al. Primary lymphoma of the pituitary gland, an unusual cause of hemianopia in an immunocompetent patient. JRSM Short Rep 2012-38, 55-9. Case number 10, 2 different patients. B. A. Metastasis, lung cancer, 10A, and GBM, 10B. Clinical. Only 1–2% of intracranial metastases are extraparenchymal or non-meningeal, typically more infiltrative. Breast cancer is most common, followed by lung, kidney and colon. Glioblastoma multiforme and anaplastic astrocytoma are the most common primary sites from the brain. May present with diabetes insipidus, anterior pituitary insufficiency, retroorbital pain. Median survival after diagnosis is 4.1 months. Positive prognostic indicators include solitary pituitary metastasis, good performance status and receipt of local therapy, not age, gender or primary cancer type. Imaging. Enhancing lesion, typically small, round and infiltrating. May mimic many other lesions, no pathognomonic distinguishing feature. Must include in patients with a known primary and enhancing pituitary mass. DDX, macroadenoma, lymphoma, sarcoid, lymphocytic hypophysitis. Texas, radiation therapy and/or chemotherapy and/or surgical resection. Okio M. Myref, Lors, asymptomatic pituitary metastases. Journal of Neurosurgery 1998-89 1, 69-73. Lin C., Huang W., Chung F., et al. Prognostic Factors in Cancer Patients with Symptomatic Pituitary Metastasis, a Clinical Case Study. Anti-Cancer Research 2015 35-2, 983-7. Ametam, Truyeres, Andre M., et al. Pituitary metastasis presenting as diabetes insipidus, a report of 4 cases and literature review. Review of Internal Medicine 2009 35, 425-9. Case number 11. Case number 11, continued. Epidermoid clinical imaging. May present with headache, cranial neuropathy, visual disturbance, hypopituitarism, diabetes insipidus. Mean age of presentation 40 years, equally common in males and females. Usually very slow growing, rarely degenerates into squamous cell carcinoma. Rupture may lead to chemical meningitis. 10% are paracellular. Imaging. Predominantly non-enhancing, may have minimal peripheral enhancement. CT, lobulated, hyperdense mass, 3% hyperdense due to prior hemorrhage/high proteinaceous content. MRI, cauliflower-like lobulated mass, slightly hyperintense to CSF on T1 and T2, diffusion restricting, insinuates cystins and encases neurovascular structures. White epidermoids hyperintense to gray matter on T1 due to high triglyceride/fatty acid content. Black epidermoids hypointense to CSF on T1 due to solidification of cholesterol and keratin. DDX, Rathke cleft cyst, craniopharyngioma, neurocystis abscess. Texas, surgical resection with tendency to recur. Costa F., Fonar M. Felicity G., et al. Epidermoid cyst of the pituitary stalk, case report and review of the literature. Neurosurgery Quarterly 2013 23-2, 108-11. Law E., Lee R., Lung A., et al. Atypical intracranial epidermoid cysts, rare anomalies with unique radiological features. Case reports in Radiology 2015 to 2015-4. Case number 12. Mucoepidermoid carcinoma, mimicking craniopharyngioma. Clinical. Typically a salivary gland, parotid most commonly, neoplasm containing mucus-secreting cells and epidermoid cells. Most common primary malignancy of the parotid gland. Those with prior radiation therapy are predisposed. May present with facial nerve paralysis, facial pain, enlarging facial mass. Imaging. Low-grade lesions are well circumscribed, while high-grade lesions are invasive and irregular with associated lymphadenopathy. Low-grade lesions tend to have cystic areas while high-grade lesions do not. Hypointense T2 areas are characteristic. Heterogeneous enhancement. Must evaluate for perineural spread, CN7. DDX, craniopharyngioma, macroadenoma or Rathke cleft cyst, in our patient, benign mixed tumor, Warthin tumor, lymphoma, adenoid cystic carcinoma. Texas, surgical resection plus/adjuvant radiation, neck dissection if high-grade. Triantafyloduque, Dimitracopoulos J., Iodinides F., et al. Mucoepidermoid carcinoma of minor salivary glands, a clinical study of 16 cases and review of the literature. Oral diseases 2006 12-4, 364-70. Vanfort W., Smith H., Horvath et al. Salivary gland-like tumor of the silla. The Canadian Journal of Neurological Sciences 2007 34-4, 478-82. Case number 13. Lymphocytic hypophysitis. Clinical. Inflammation of the anterior pituitary gland which is idiopathic. Much more common in females, typically in the fourth decade. Up to 40% misdiagnosed as adenoma. Imaging. Features more indicative of LH, symmetric enlargement of pituitary gland, thickened pituitary stalk, greater than 2 mm, intact sellar floor. Homogeneous enhancement. Parasility 2 dark sign, hypointensity 2 signal around the pituitary gland and cavernous sinus, not seen in patients with adenoma and often progresses with chronicity in patients with LH. Our patient did not display this sign. DDX, adenoma, pituitary hyperplasia, metastasis, sarcoid. Texas. Steroids and hormone replacement therapy. Secondary panhypopituitarism may lead to death if untreated, however can be self-limiting. Gutenberg A., Larson J., Lupi I, et al. A radiologic score to distinguish autoimmune hypophysitis from non-secreting pituitary adenoma preoperatively. AJNR Arm J Neuroradial 2009-30 to 1766-72. Nakata Y, Sato N, Masumoto T, et al. Parasility 2 dark sign on Mr. Imaging in patients with lymphocytic hypophysitis. AJNR Arm J Neuroradiology 2010 to 31 to 1944-50. Quensera lymphocytic adenohypophysitis, autoimmune disorder of the pituitary gland. AJNR Arm J Neuroradial 1980 to 1:343 to 5. Case number 14. Rossi-Dorfman, sinus histiocytosis. Clinical. Unknown etiology, may be autoimmune or infectious. Typically present in first or second decade with painless neck mass. Massive bilateral cervical lymphadenopathy. Other SX, anosmia, facial pain, epistaxis, visual disturbance. Benign entity, however morbidity increases if superimposed immune disorder present. More common in males, African and West Indian heritage predominance. Imaging. May see involvement of dura, orbits, bone, skin and salivary glands, rarely involves airway, mediastinum. Huge, enhancing lymph nodes. MRI, T1 and T2 hypointense, enhancing and infiltrating extranodal lesions. DDX, lymphoma, meningioma, metastasis, histiocytosis. Texas, watchful waiting, steroids, surgical debulking if compression of adjacent neurovascular structures. Labarge D., Salzman K., Hansberger H., et al. Sinus histiocytosis with massive lymphadenopathy, Rossi-Dorfman disease, imaging manifestations in the head and neck. American Journal of Röntgenology 2008 to 191-6, W299 W306. Simpson, Kugati G., Wasuvan M., et al. Intracranial Rossi-Dorfman disease, report of 3 cases and literature review. Asian Journal of Neurosurgery 2010, 5-2, 19-30. Case number 15. Case number 15, continued. Prior to Texas. 5 days later, after steroids. Perineoplastic syndrome. Clinical. Less than 1% of cancer patients develop perineoplastic syndrome. Most do not have imaging findings. Most commonly due to small cell lung cancer, followed by breast cancer, gynecologic tumors and hematologic malignancies. May present with seizure, altered mental status, memory loss. Immune-mediated response, Greater than 50% have autoantibodies and or specific surface antigens, as were found in this patient. NMDA receptor UB, mGlu1 UB, voltage-gated K+ channel UB, UB, YOUB, REUB, CV2 UB. Imaging. Limbic encephalitis, T2 hyperintensity throughout the mesial temporal lobes and limbic system. Brainstem encephalitis, T2 hyperintensity throughout the brainstem, as well as the cerebellar peduncles and basal ganglia. Cerebellar degeneration, atrophy. DDX, metastasis/lymphoma, in our patient, herpes encephalitis, glioma. Texas, treatment of primary tumor, supportive therapy including immunosuppression and electrolyte/hormonal correction. Dalmau J. Rosenfeld perineoplastic syndromes of the SNIS. Lancet Neural 2008-74, 327-40. Pelisoff L. Gerber D. Perineoplastic syndromes, an approach to diagnosis and treatment. Mayo Clinic Proceedings 2010-85-9, 838-54. Key points: cavernoma, arteriovenous malformation, petrous apex aneurysms. CT, well-delineated hyperdense mass plus/calcification, MRI, popcorn appearance, hypointense hemosiderin ring on T2, blooming on GRE, minimal/no enhancement, look for associated DVA. Arteriovenous malformation. Bag of worms, tangle of vessels, MRI, honeycomb of flow voids, enlarged feeding arteries/IS and early draining veins. Petrous apex aneurysms. CTA preferred diagnostically. MRI can demonstrate hyperintensity 1 signal with cholesterol granuloma that appears as flow-related signal. Macroadenoma. No separate pituitary gland identified. Pituitary apoplexy. CT hyperdensity, MRI blooming within the cilia, rim enhancement suggests underlying hemorrhage, may have associated subarachnoid hemorrhage. Meningioma. CT, most hyperdense, may be partially calcified, underlying bone hyperostotic, MRI, hypo to isointense on T1 and T2, look for dural tail, early and prolonged enhancement, mother-in-law sign. Key points: chondrosarcoma, chondromyxoid fibroma, pituitary lymphoma. Typically centered at the petro-occipital fissure, chondroid matrix calcification on CT, MRI may demonstrate whorls of enhancement. ADC values may show benefit in distinguishing from chordoma. Chondromyxoid fibroma. CT, geographic lesion with a sclerotic margin, thinning of cortex, usually expansile, MRI, T1 isointense, T2 hyperintense with lobulations, minimal enhancement. Pituitary lymphoma. Typically hyperdense on CT, MRI, T1 and T2 iso or hypointense, may restrict homogeneous enhancement except for possible areas for necrosis. Metastasis. Must include in patients with a known primary and enhancing pituitary mass. Epidermoid. Non-enhancing, cauliflower-like lobulated mass, slightly hyperintense to CSF on T1 and T2, diffusion restricting, insinuates cystins and encases neurovascular structures. White epidermoids hyperintense to gray matter on T1 due to high triglyceride/fatty acid content. Black epidermoids hypointense to CSF on T1 due to solidification of cholesterol and keratin. Key points: mucoepidermoid carcinoma, lymphocytic hypophysitis. Hypointense T2 areas are characteristic, must evaluate for perineural spread, CN7. Lymphocytic hypophysitis. Symmetric enlargement of pituitary gland, thickened pituitary stalk, greater than 2 mm, homogeneous enhancement, paracellular T2 dark sign, low T2 signal around the pituitary gland/cavernous sinus. Rossi-Dorfman. Huge, enhancing lymph nodes, MRI, T1 and T2 hypointense, enhancing and infiltrating extranodal lesions. Perineoplastic syndrome. Limbic/brainstem encephalitis, T2 hyperintensity, cerebellar degeneration with atrophy, serum markers necessary in atypical cases.